Who is one from an organization working on integrating digital health into the different healthcare ecosystem. And today we have a pleasure to have him just to give us a short overview what they are doing. But first, we will start with just to give a talk on how preparedness can be an operating system. So we'll hear from Michael, and then we can have a demonstration session when he can show how their platform works, and then we'll go through a session of question to know how we can integrate this in our daily work. So I will call upon Michael just to introduce himself, and then to go with the presentation.
So,
Michael, the floor is yours.
okay, so first of all, kind of Asene, Daniel, thank you very, very much for organizing this and for Dr. Katoto, Professor Katoto, for organizing this. And I want to thank Dr. Masoka Fala and Misaki for introducing me to your ecosystem. And I'll give you a little bit more background on myself, but I do know that typically in an African meeting, because most of you are looking at me and thinking, who's this Mzungu? I don't know how many of you know the local terms Mzungu or Igbo, right? But I've actually been very involved in Africa for well over 20 years. And I am Akiki from Two Kings in Uganda. So I don't feel a Mzungu, and I hope you don't treat me like a Mzungu. And I want you all to know several of my team are on the call. And everything that we have built has been in Uganda, in Africa, for Africans, by Africans. So everything that we have designed has been designed, kind of not as we're the smart Americans and we're going to eat this, it's good for you. No, no. Everything we've built has been built and designed in location. And the other very important thing is that we have not built one system. We've built infrastructure, and our goal in working with you is to co-create, because clearly over the last 10, 20 years, with all the money that's been spent on this program, that program, the other program, it's not worked as well as people had hoped. You guys are the experts, academics. We're the experts in tech. Do is to be able to work with you and co-create what is the perfect combination between technology, and professional knowledge of how to actually treat things on the ground. And they need to be entwined. Now, one of the things that's also very customary, as I've been involved in many larger discussions in Africa, is that you always start with a little prayer. Now, I'm Jewish, so we pray to different intermediaries and deities. But I must tell you that I pray for all of you on the front lines very regularly, because you are really doing God's work. And you're doing God's work not just for your local people, but you're doing it for the world. So I just want to give you my blessings, and I am sure that God and his presence is going to be guiding these discussions, because they are timely and extremely critical, and really is a massive service to humankind. And all of you who are involved on the front lines are real heroes. They're real, real heroes. Now, a side request is I love it when I can see people's faces, because then it's easier for me to see if I am, if I'm boring you, if you're falling asleep, if you're, if you're engaged, or somebody will go, oh, roll their eyes. It's very valuable to me as a presenter, because I don't want to be one of those long, boring guys that just goes on forever. So Professor David and Ebenezer, I appreciate you being there with your smiles and your encouragement. It's very important, because as I say, what we're looking to do with you is to co-create. We're not looking to come and say, eat this, it's good for you. We're here to say, all my team are all Africans. They're all in Uganda, some in Kenya, but everybody's very familiar with Ebola and all the different challenges of lack of access to tools that really should be accessible. And that's what we've done. We've built an infrastructure that makes all of these amazing tools accessible to the point that we've built better tools for Africa than exist in America. So with that as the background, now I'm going to give you first a short presentation, a PowerPoint, which was co-designed with Professor Misaki, because he said, Michael, I know my people, don't go and give one of your long, boring, taking over the world projects. It's going to confuse people, right? Just trust me. And I confuse everybody when I talk. I confuse myself because we've built a lot. But he said, follow my lead. So what I'm going to show you now is the lead of Dr. Misaki, and hopefully he'll be able to join us very soon. So I'm going to share my screen. So my company is called Life Health, CTI Life Health. We've been around for about 6 or 7 years, but we've been more in stealth mode than we're not selling. We're looking to build the infrastructure that ultimately is going to manage healthcare for Africa. We've built systems that the governments of every country should want to deploy them in their countries. Health records for individuals, records for health workers and know where they are and to be able to be interactive. We've built systems for hospitals. We'll build data management systems. So I'm going to share that with you. And then recently, some of you may be familiar with In-Depth Network, which is was a group of doing population health, and I partnered with them, and we just received a small grant from the European Union called SINCEP. It's called SINCEP Africa. Some of you may be familiar with that, and it's a population health program and surveillance program in 13 countries. I believe one of them is in the DRC, and doing population health for 4 million people. But it's very basic. It's HDSS information. It's not detailed medical. We're obviously hoping that we can expand that, but we are the technology partner underlying all of that infrastructure. And the goal of the EU's program of supporting the SINCEP Africa and the In-Depth partners together with the Africa CDC is to create the future of pandemic preparedness, right? This is the prototype, and it's a 5-year program. So in my discussions with some of the senior people at the Africa CDC, it became, first came hantavirus and then came Ebola. And I said, you guys are flat-footed again, right? Now everybody's busy chasing backwards. It took 2 months till it was identified. I mean, and so everything that we are building, and that's why when Arsène sent me over the headline of the title of the program, I said, okay, this man gets it. And that is preparedness as an operational system, right? The idea that it's not about how do you catch somebody now 2 months later with a problem? How do we make sure that when in the village, if 3 people get sick, we know about it straight away? If 2 people die, we need to be able to investigate it immediately if they die unusually, right? So the question is how do you do that, right? And that is the ecosystem and infrastructure that we have built and that we want to be able to share with you. But as you see here, preparedness as an operational system, digital health support for DRC's Ebola response, and the idea is to create a practical pilot to strengthen informational flow across surveillance, laboratories, case management, and response coordination. So why this matters now? Well, the DRC, unfortunately, seems to be sometimes at the bit of the epicenter, but continues to face recurring Ebola outbreaks. And the operational need is simple: move trusted information faster. early signals to reach the right response teams, laboratory status to be visible and traceable, etc. Now, I'm not very good at giving presentations from PowerPoints because I generally feel you can read what's on the PowerPoint, right? But tradition dictates that I'm supposed to read what's on the PowerPoint, right? But maybe it reinforces it a little bit. Anyway, facilities need a connected view of suspected and confirmed cases. Leaders need actionable data without slowing the field response. So the concept here is that the gap is the informational flow. Right. So in an outbreak, you've got a case alert, a patient needs to be identified, you need to have the sample status, you need to coordinate the care, and then you have the authorized reporting. So Life Health creates that connected layer so that the right information reaches the right people at the right time. The idea of the pilot that we would love to do together with you is to take Bunya, Kasenyi, Aru. I hope I'm pronouncing them not too badly as a Mzungu. But the idea is to create in selected health zones to deploy what I'm going to show you. And so that way we can support the urgent workflows, validate the local adoption, prepare for scale up. And the word that I didn't include here, but the most important word is trust. Right? People, the local people have to trust the system. They have to trust that they're not being taken advantage of, etc. So how Life Health supports the response, this is identify the case, register digitally, alert the response team, track sample and lab status, support the case management, generate automated reports. And this, as I said, this piece of the presentation was designed in cooperation and collaboration with Misaki, with Dr. Misaki, Professor Misaki, who some of you will know, because he wanted me to present to you something that was practical and real that you guys are facing and dealing with all the time. Because I have a tendency, because the system we've built is for universal healthcare, for plug and play adoption in a whole country, there's a lot of features. Said, Michael, keep it focused. So the idea here, the value proposition of what changes and what we bring, faster visibility for the case lab signals to move faster across response, country controlled data. So you want to keep all the data in a sovereign cloud, however you want to do it. Stronger coordination between the facilities, the labs, response teams, and everybody is coordinated. So now it says, let's see the demo, okay? So I'm going to stop here for a second in case anybody's got any immediate questions, or if Daniel, if my presentation is not good so far.
No, Michael, it was excellent.
All
And
right.
so,
So
if the colleagues have questions, I think this is the right time before we go to the practical session. But for me, the only thing I would like maybe to know in terms of the infrastructure itself, what are the requirements? And as you know, maybe sometime access to the internet could be one of the most important things to make sure the system is working. So how do you manage or anticipate this kind of issues?
So I anticipate that when it comes to connectivity, which is obviously very critical, right? We're in a new world of technology, and we're in a world of Starlink, right? And we're of Starlink, and Amazon is looking to do something competing. So in my vision is that the president of the DRC puts in a phone call to Elon Musk and says, we need you to provide connectivity. And if you don't, we will publicly tell the world that you refuse to do it, right? And even without that threat, Elon Musk happens to be a huge humanitarian, and he will do it. The problem is that the coordinating pieces of a little program here and a little program there and a little bit of ministry here and there is not strong enough, even though the world is fully aware of the crisis of Ebola and where it can go and what it can do, right? And again, and this is obviously about Ebola now, and it's about a bit of Mpox, but it's about creating the infrastructure that these things will not happen in the future. And that in the future, if there is a, God forbid, another Ebola outbreak, you know about it after the second person dies, right? And it doesn't become this. So this needs to become a movement, right? So whether we are engaging with Dr. Kasaya, the Africa CDC, and he has a beautiful photo up with the president and with the minister, and we'll say, you guys must get on the phone with Elon Musk. And we need to make sure that we create a comprehensive, initially, East province, and then country, and then Pan-African comprehensive infrastructure, that we make sure that every health worker and every health facility has got access to the internet, and that you provide it at a reasonable cost, right? So is that realistic? Absolutely, it's realistic. Is it realistic for somebody in a, kind of in a, at a, whatever? I'm telling you that is very realistic, right? And it's what's needed. And those are easy things. Those are the easy things to get done. It just requires the will and the commitment to make it happen. Because you already see that he's already promised devices. So if you can promise 150 and his company's worth $2 trillion, he can provide a few more. But if we go ahead and ultimately build a proper infrastructure for the country, so that the whole country is covered, every health facility, as I will show you in a moment, is covered, right? And everybody in the country has got a life health passport. Every health worker has got the life health nexus. That we will create demand. We're going to create businesses that the same people that are in the villages, helping the local health workers, helping the local people, they're going to end up becoming little businesses, because they're going to now sell eyeglasses, hearing aids. They'll deliver for Amazon in the villages. We are coming with a very big, scary vision for most, right? But very practical. And there's no reason why, with a group of excellent, brilliant people like yourselves, that we can't start proving that the world can be better. So allow me to continue the little, again, forgive me for pontificating a little bit over here, right? I apologize for that, but I'm very passionate, and I know that we can create the future, and especially if we work and co-create together. So let me give you a quick view. So this is a dashboard about in an area called Buwikwe in Uganda. And over here, we've got 47 health facilities. Who owns them? So we've got the different ownership structure, right? How many are open 24 hours? How many are open, what level are they? How many HC3 level 3s are there? Okay. There are, you'll see pop up over here. They'll bring it down. There are 18, right? My computer's just a little bit slow, right? And then how many have got an HIV department? How many have got a research department? How many have got a pandemic preparedness infrastructure, right? And the way we manage this initially is we've got these forms that we create that, using a smartphone, an administrator or a health worker from Central can go to a health facility and go and collect all of the data, including who's in charge, what's their number, how do we communicate with them, how many staff members. And I'm just going to use sickle cell treatment as an example, because it's what we've done, what we've been focused on in Uganda. So when you click on the deep dive button for sickle cell, it'll bring you to the 7 facilities that have got sickle cell. And then you'll say, okay, how many have got a hematologist? How many take care of pediatrics, of children? How many offer folic acid because somebody's allergic to hydroxia? Click, 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 2 facilities, right? And now you've got all of the data that you need, right? So, and it's all based on collecting real data, right? And it's not rocket science to collect the data. And then once you've got the data, we can provide tools to the health facility, even to be able to go, how many cases of what were there today? And with that, we're able to now go and determine how many COVID, how many Ebola, how many babies were delivered, how many whatever it is, we can now easily calculate. And all that's needed is a simple tablet or a simple smartphone in the local facility. Right? And I can spend a lot of time on all of this. And we've got a button called the Life Connect, which connects. So once you've done a filtering, you can then go and communicate with all of the people. So this is the example there. Now, this already is an example of what we call the sandbox. Because let's say you've got, this is how you manage. The example that I like to give is of blood banking, right? So we've got a system that we collect people's blood type. It's a card, a little card. Another one is a cassette. But we think it's very important and it's very cheap. And we think it's very important to know people's blood type, whether it's for clinical research later on or whether it's because a woman's having a baby. So again, the example I like to use, kind of as a young woman's having a baby in the parish of Lagoba. So you can now go and type in Lagoba. And by the way, all of this now, we are adding layers of AI that instead of even having to type things, you can just speak to the phone, speak to the computer to give you data and analytics. And I can show you on the patient forum, right, on the patient passport, how people can just speak to the phone to get data. So here we're in Lagoba, and then you can then go and break it down to, okay, if you actually, that a young woman, she needs O negative blood, you can see who's agreed to be blood donors. And the idea is that you can just click, 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 and then you can find out exactly. So it's analytical tools. So you'll be able to now, if there's an outbreak, you'll see, okay, here is an outbreak. There's an outbreak right here. Then you'll see, okay, which is the nearest health facility. And all of this is done digitally, right? And then we've got over here, which is the village health teams, right? Let's, in this area of Bawikwe, there are 1,300 village health workers. So let's analyze them a little bit. Which of them carry medical equipment? Which ones have got, a health information system? Which ones have got access to the internet? So you're going to end up with a couple of hundred. So now, and the map, as I say, my computer's just a little slow. But the idea then is that we can now overlay where the nearest facility is, where the nearest health worker is, right? And then where is the person who's got the outbreak, who's got the problem? And now we can go and communicate and go and send them over to deliver. In the meantime, with the sandbox, we can drill down to any particular diseases, and we can do disease heat maps. You've got all of these data forms that we can use for any particular problem. So if somebody's got, Ebola, you want to be checking on them and seeing how they're doing. We've got systems designed for clinical trials, analyzing all the staffing. Let's say you say, okay, you need to know, who do we send, right? Who's nearby? Who do we send? Who's got the experience? So we'll build all of that infrastructure, right? Kind of for you. Now, the other thing that we've got, and I'm going to show you this from the perspective of the patient and the phone, but this is from the perspective of a patient using our system on a computer, right? Which most people in the DRC won't have. They'll have phones, but you'll be able to have tablets. You'll be able to get access. So this is what a patient's record looks like. They can book an appointment, call the doctor, upload their medical records, right? They've got their overview, checking on their vitals. You'll be able to see kind of all of the vital results, where they come from, right? What the averages are, all the data. And if you can break it down to the source of the data, it's just a very, very powerful tool. And this is the nexus. So when you as a doctor, a patient has got the system and now they've got Ebola and you want to check on them, you don't need to sit there and take a risk of your life. You can actually have the patient call you on the phone as a telemedicine, and you can have a complete profile and overview of your patient, what medication they're taking. You can be tracking them and seeing how well are they improving, not improving, all of them just by getting a phone. Now you're going to say, well, a lot of these people don't have phones. Well, if somebody's got Ebola, it's cheaper to give them a $50 smartphone so that they can be tracking their health. So let me stop sharing here, and then I'm going to quickly move over to share my screen on my phone. And again, I'm not going to go into too much detail. I'm not going to do too much detail, but I'm just going to give you at a high level. So this is the patient app. right? This is an app that the patient will have. And again, and this is something that we would want to work with you, that you're going to say, hey, Michael, we need this. Forget about Ebola. This is something that every person in the DRC should have. We want all of our patients to have all of this stuff. How do we evolve this from just doing it for Ebola and for Mpox and to turn this into really what every person should have? We've already built solutions that if people don't have a smartphone, that one health worker with a tablet can manage 500, 1,000 people in their neighborhood and doing it. But here you've got the ability to put up all your medical records, you've got your appointments, you've got your vitals. We've even got a tool. I'm not going to do the whole thing, but we've got a tool over here that just you can do a face scan. And at the end of a 50-second face scan, you've now got the pulse rate, the SPO, the blood pressure, the respiration, the stress level, the wellness level of the person, right? So there's so much stuff that can be done even without you being present with the patient, right? Which makes life so much safer for all of you, but it also means that you can follow up on the patient. And we are at the cutting edge of latest technologies. And I know many of you have been working with Mpox. So we're in contact with the Stanford University, who've got an AI tool to identify Mpox and to see if it's Mpox or if it's just a rash. Or so the idea of the co-creation over here is that let us do the technology, tell us what it is that you want us to find, and we build it with you. Right. So over here, you've got all of your medical records. Now, you've got so many different ones, it can be confusing. So now let's just do the facial scan. Right. And then you've got education, explanation, your lab results. You've got the ability to go and call the doctor. So now the patient can be calling the doctor. And when you call the doctor, you can be explaining exactly what's wrong with you and take a picture of what's wrong with you. And then when you express clinic and go and call directly to the doctor, or the doctor will answer the phone with all of your information, we can set you guys up with your own telemedicine, right? So that the telemedicine can now be, can just part of the feature. You make a rotation and you have different doctors available 24/7 for these patients with Ebola or Mpox or whatever it is, to be now just ready, set, and available for, for any interactions that you need to have. The doctor's taking too long to answer. So, and again, there are loads of other features, including this one, Hi Vima. I'm going to push here. Hi Vima, kind of how's my blood pressure doing today? All right. Now, it's not going to work because I'm speaking with you, right? So it's not going to get. So you say, how's my blood pressure? All right. How's my blood pressure? Well, right? And then it's going to be checking my blood pressure. It's going to be checking all of my records, right? And we can program this for you based on specific needs and specific requirements, right? So look at this. It's telling my blood pressure reading the past few weeks has been looking good. Most recent one, 115 over 75, etc. And it's speaking to me. I don't know if you guys can hear, right? But Vima is speaking to me, right? So anyway, there are lots of other features over here, right? And then this is the app that the health workers have got, right? And by the way, we've got verification tools, so you can verify the patient using biometrics, verify the doctor using biometrics, and you can go and verify time, date, location. So as you want to be able to prove, no, this person went to this patient's home and gave a vaccination. So here we're going to go and look for Michael Landau. So, and then when you go to Michael Landau, you're going to view Michael Landau's record. So your individual patients will be listed under you. And now I'm going to go ahead and do add a vaccination. So I'm going to go and add a vaccination manually. So I do, hepatitis A. I do the auto capture. So with the auto capture now, it's going to tell me the date, the time, the location. I'm going to be able to scan the barcode, right? And you'll be able to scan the barcode so you can know exactly where, when, what, everything has happened. So with this tool, the health worker can be with the patient, and you can add users, add blood type, order things. We've got devices called a MedWand, which is, I don't have the physical device in front of me, but it's now, again, let's go to an existing patient. It's a small handheld device that has got it's got a stethoscope, an otoscope. It's got an ECG. It's got a thermometer. it's got an SPO on it. So now when I want to go and see, kind of take a look at what was done, it's got the dermoscope on my hand. It's got it can look into my ear. It can give you the ECG copy of the recording. It's a complete infrastructure. Anyway, the system, as you can see, just goes on and on and on. So I know I tend to overwhelm people, but the main point here is that we've built infrastructure, and with God's help and with your co-creation with us, we can build the future of healthcare. And we're going to start by creating the preparedness and for the Ebola response to make your lives easier as medical professionals and to make the life of the patients easier, better, get them healthier, faster, and to make sure that this doesn't happen again in the future. So Arsène, I hope I haven't spoken too much. I know I've taken a lot of time, but I think this is very important. My apologies if you guys feel that I've wasted your time, but that's
Thank you very much, Michael. So the presentation was just terrific. Um, so I think we heard a lot about your platform and the potential it can bring in terms of health support, in terms of also research. So I will ask my colleagues if they have some question, so they can just open their mic and speak freely, so we can dive more into the discussion and see how we can um, maybe initiate some collaboration, or how we can work together in order to make sure this can support actually the response in DRC. Over to you, colleagues. If you have any question, just open your mic and speak.
Yes, doctor, I've got a question.
Uh, Go ahead, Mr. Bang.
I would like to know what is the level of reliability of that cutting edge technology nowadays? Do we use it in all the structures in enough countries, or are there any scientific proof that there will not be bias in terms of results coming from this technology? What is the level of reliability? Thank
you
you.
guys are the researchers. You'll tell me. We're going to start using them, and you'll tell me, Michael, these are biased. They don't reflect what we see on the ground, and then we'll test it. I mean, I'll give you a prime example of a situation. So, one of my, some of you may know him. One of my friends is Professor Colin in Zimbabwe, and he is one of the leading genomic experts. And we've got a major program we're looking to do with genomics also. And he told me that when the AIDS virus first came, and they were developing all the drugs in America, because that's, where's Africa? Who cares about Africa? Right? That's, so they developed all the drugs in America, right? And I'm trying to change all of that, right? So they designed the drugs for America, and then they brought the HIV drugs to Africa, and they weren't working. They just weren't working. And he then went and did some genomic testing, and he saw that the typical African metabolization of that particular drug was too slow. And therefore, the drug was fine. They just needed to increase the dose, or maybe it was the reverse. They needed to reduce the dose. I don't remember which one. But when you did the research, they found that, okay, it was good. It needed tweaking, right? It needed tweaking to work. I cannot tell you, because I've not deployed these solutions in an Ebola environment, in the DRC. These are the solutions that we're bringing are being developed, kind of in really smart places, and we are looking to bring them all over the world. And so I cannot sit here and tell you that they are 1000%. I can tell you that before we do anything, we'll give you all the literature, and you can then go and investigate all the literature. And then, as most of us, I assume, on this call are, have got some level of research capacity, we will actually be following up on, because all the data we collect is all digital, right? So we are in the perfect position to track Are these drugs working the way they should? Are these results reflecting the way they should? Are this medication that we gave to somebody for a heart condition based on, the facial scan? Are they, there seems to be something wrong. We will work together to identify what's working well, what can be improved, and what shouldn't be used in our environment. I hope flippant answer. It's a very serious, we will build the future because we don't know everything today. I hope that answers your question, Dr. Banza.
Yes, thank you, thank you, sir. It's amazing. It's an amazing tool, and we hope that we are going to employ and use it adequately. Thank you, sir.
Thank you.
Thank you. So I see Dr. Kakubu. Please just speak.
Thank you so much, Dr. Arsene and Dr. Michael. Unfortunately, I'm not able to put my camera on. This was quite interesting. I like the project. But I have a few questions. I've seen on the dashboard that the site will be equipped with labs. But I don't expect all the sites to have a biosafety lab level 4. But what is the basics that we need to have in those sites? And I also see with the dashboard that we will have interconnectivity between the sites, probably countrywide. With this, how do we ensure patient confidentiality? Because I see like the information can be accessible to anyone and everywhere. Thank you, over.
So you asked two questions, if I'm not mistaken. The first question was about what capacity does a particular health institution need to have to be identified,
Yes,
right?
yes.
And the answer is that it's zero. It doesn't need to have any. It means that somebody needs to be able to go there with a minimum of a smartphone, take pictures of the facility, register the location of the facility, fill out the forms of what that facility offers, right? So the facility itself doesn't need to have technology. Now, but if we can identify all the facility, it becomes much easier for us and say, Ministry of Health, you cannot have a country where you have facilities that have no access to the internet, where they don't have even a tablet. But we will gather all of that information, right? And we'll gather it because Arsene is going to send over somebody from the university and to go and check out every single facility, small, big, large. So the facility itself does not need to have technology. The more technology they've got, the more interactive them and the more productive we can help them become. So if they've got a computer, we can then give them a hospital management system, which I didn't show you, which we call the CHIP, right? The Community Health Information Platform, we call it. We call it the CHIP. But this way, the hospital can then get access and manage all of their clients in one facility. Now, you asked a very important second follow-up question. And
Sorry, for the first question, I was a bit specific on the lab. I was talking about the laboratory level that needs to have a facility because that we're talking about preparedness and we have pathogens that require a bit of experience. So I wanted to know which biosafety level need to be included in those facilities.
Listen, I'm a technology guy, so I can tell you that we have got middleware that we can integrate with your laboratory equipment. I cannot tell you which laboratory equipment you should have. We are partnered with what is it called, Siemens. We're partnered with other groups that we can make recommendations, but I don't want to pretend to say which is the best equipment. What I can tell you is that whichever equipment it is that you decide that you need over there, we will integrate that equipment so that way the health worker can create a digital order for the blood tests and they'll be able to create the barcoding that will go directly on the test tube, and the whole system will be digital, and the facility and government, wherever the legal requirements are about, okay, if you're testing somebody for Ebola, I would imagine the government says, I want to know immediately if somebody tests positive or negative for Ebola or for COVID or for Mpox, right? And that's a system that once the machine has determined what it is, and we will help the machine be as efficient as is humanly, digitally possible. The rest, which machine, that's for you to determine. I don't want to pretend to give you a recommendation, but if you need it, we can find it. So that's question number one. Question number two is about the patient data and patient privacy. Now, what we cannot do, and I'll tell you what we cannot do, is that data that is not in our system, we cannot take any responsibility for data that is outside of our system. So if you've got health workers that are collecting data and they do things with that data, I cannot take any responsibility. But what I can take responsibility for is that any data that a patient collects and deposits inside their life health record will only be accessible by the people that they give permission for that data to be accessible to. Now, the government may have laws about accessing anonymized data. So what you saw before was anonymized data. So we're not going to go and share with you the house of the person with sickle cell, but we can share the village with malaria, but we're not going to share the house. But if the government says we, at an anonymized basis, because the government are not, I don't think any government in Africa is allowed to go and know your personal system, can protect all the personal information that you put into the Life Health wallet. And then we've got a feature that allows the patient to share their record and give permission to specific doctors and health facilities. So that we can ensure stays private. Anonymized data, government have got their own, and we actually work with the patient. We take consent. So for clinical trial purposes, we take consent from the patient for us to be able to manage their data. We never own their data. We manage their data. Now, just to confuse things a little more, we've created a concept called the three sovereignties: citizen sovereignty of data, institutional sovereignty of data, and national sovereignty of data, right? So these are all, but again, because the way we look at these issues is that it's one ecosystem, it's one infrastructure. So you guys are all part of doing clinical trials in different forms of another, right? So you need to get permission from the patient. Well, what type of permission are you getting? Right? What is it for? Are you doing operations on people, or are you just tracking a little bit of basic health and everything in between? So we're working with a group called Strategic, also EU funded, but we would love to work with you. We've created a template of, depending on the level of invasiveness, the level of risk, the various levels, what sort of consent should be collected from the patient. And we've actually created a dynamic consent infrastructure that uses cartoons to be able to explain to people exactly what it is that they are consenting to, what the risks are. You program it. We've just created it to make it easy. So again, I hope I'm answering your questions, and I hope I'm not confusing you, and I hope you feel that we have created infrastructure that it's a little bit like a master restaurant. We've got Chinese food, American food, DRC food, and then you can choose appetizers. We've got a lot of choices that we've built because we want to be the infrastructure to ensure the future of my children and grandchildren and yourselves and your children and grandchildren.
Okay, so I've seen something in the chat from Professor Lupande. And I'd like just to remind colleagues, if they have any issue with their mic, if they are not able to speak for one or any other reason, they can just type in get in the chat. So Professor Lupani would like to know, when will the implementation of this will happen on the Ebola ground?
Well, that's not a question for me, actually. That was my question for you. All right. You're the ones who've got to say, hey, we like this and we want to pilot it and let's try it. And again, I'm a business, right? I'm not a philanthropy. I'm a business, right? And so I'm not looking to make a lot of money, but it costs us money to deploy this, to design something. And there's a lot of people throwing a lot of money at the DRC and Ebola and Mpox right now. And so I think together, we should be able to go and get the funding to get it started. But what I did commit to Arsene yesterday or 2 days ago when we had our first conversation, we can start giving you tools. So we can, even if there's no money, there are certain things that we can start doing. So we can help create tools for you to identify your health workers. There are tools that we can start doing to start identifying health workers, that all of you, so we can create a proper registry so you guys can be well organized amongst yourselves. We can start giving you, kind of the tools for the nexus, right? There are things that we can start giving you some basic dashboards and start evolving it. Now, ideally, this, as I said, there is a lot of money. And unfortunately, and again, the money tends to not go to real practical things, right? And that's something that I hope that, all of you, I'm assuming if you're part of the university and you're practical and you're operational and you're on the ground, will see the benefit of our platform, but all of you will have had some level of interaction with how grants work and how different things work. So I'm not good at that. I'm really, really not good at that. My team's not good at that. We're very good at thinking up solutions and deploying solutions and being very practical, right? We've got good business models on the back of this, meaning that if we now know, for example, I don't know what else you guys do, but if you guys are doing other medical research programs, we can create great tools for you to be able to follow up with your patients more efficiently, faster, to be able to go and get, let's say you're doing a pharmacovigilance on a particular drug, right? And you've got a pharmaceutical company that's paying you. Well, leverage our solutions, right? And so therefore we can make a bit of money. But then once we identify, for example, we're looking to do a project with the Lung Institute in one of the countries. Well, if we can now identify that there are 2,000-3,000 patients that are using a nebulizer, or there are 2,000 patients that are using spirometers, well, we can negotiate with those companies, offer it at a discount, make some money, track how well they're doing, and whoever's our partner can also be benefiting from it. So there are a lot of big, beautiful collaboration opportunities that hopefully each one of you on this call can walk away from and say, wow, the Life Health platform, this is really brilliant. We can use it in so many places. And then I'm going to say, Arsene, who amongst that group over there can work with us in DRC and be our coordinator with all for the avalanche of, please God, opportunities that are going to come across our desk. But anyway, I digress a little, but not really, because if projects aren't sustainable in the long term, they don't survive, and then the results get lost. We are looking to create something which is very sustainable for the long term and beneficial for all stakeholders in the long term. And we want to build this with you.
Wonderful, wonderful, Michael. So I would like to ask colleagues if they still have questions. So we'll take one more question before we...
Ziga's question, the answer is yes.
Yeah.
The answer is yes. We've already built that. We've actually got a little video on our website, lifehealth.global, and you go to Life Health TV, and you'll see we've already built that offline online capability. But yeah, and as I said, a lot of what's going to happen over the course, if I, the question that we got before, we're going to be co-developing interesting things as we move forward. So.
Thank you very much, Michael. So I think this solution will be very efficient, and as an academic and research institution, so I think this platform has many potentials, and I would like maybe we continue the discussion and see how this can support our ongoing activities. So as we are going to the end of the session, so maybe I would like to call Professor Katoto, if he have a word, so he can take the floor and maybe also conclude this session. Prof. Katoto, the floor is yours.
Thank you very much, Dr. Daniel, for organizing this, and my appreciation to you, Michael, for your availability and the enthusiasm, passion to collaborate and to improve health in your African continent. Right? You are not a Muzungu anymore. You're just an Ugandan. Now you'll be a Congolese one. So I think this is a very good opportunity to see our brother working with us to really address a very important question. Data is really a very big issue in Africa, and I believe that this is a beginning for data sovereignty. This is a beginning for patient care improvement, personalized medicine, justice, equity, and I really believe that the next step is the implementation of this project at operational level. And I would like to call you, Marco, again, and Professor Misaki and Arsene, maybe now to have a small team to start work on underground. So Arsene will put a commission in place that will be meeting with Michael regularly, and so we can, with one objective, how do we operationalize the project at granular level, not at national first. We pilot at one health zone through the whole health system pyramid, working with one health zone, and then we can start connecting different health zones. And I believe we will have, there are a lot of calls for where we can grab some budget, etc. And we can also look for catalytic funding here and there and start working. And of course, training, mentorship. I believe we can also have colleagues who can specialize in this field, so we can have the future Michael as well in DRC. So thank you very much, and I wish you everyone a very good afternoon, and thank you, colleagues, for your time to join the meeting.
Bye-bye.
Thank you very, very much. I hope this is the first of the future. Thank you.